All right. Good morning, everyone. My name is Sachin Jain. I'm Co-Editor-In-Chief of Healthcare, the Journal of Delivery Science and Innovation, and Consulting Professor of Medicine at Stanford University School of Medicine. Great to be here with all of you in these unprecedented times to talk about the impact of the COVID-19 crisis on global healthcare as well as U.S. healthcare. I'm thrilled to have with me today two close friends, Dr. Ashish Jha, who is Professor of Medicine at Harvard Medical School and the Harvard School of Public Health, as well as the Director of the Harvard Institute for Global Health, and the incoming Dean at the Brown University School of Public Health, as well as Bryony Winn, who is most recently Chief Strategy Officer of Blue Cross Blue Shield of North Carolina. Ashish's remarks will focus on the global impacts of the COVID-19 crisis and lessons from a global perspective. And Bryony's remarks will focus on the impact of the COVID-19 crisis on the long-term sustainability of the U.S. healthcare system. I will now turn it over to Ashish, who will share his perspective.
Great. Sachin, thanks so much. And good morning, afternoon, and evening, depending on where you are across the globe. As Sachin said, my name is Ashish Jha, and I'm going to get us going by spending about 10 to 15 minutes on giving you an overview of where we are with the COVID-19 pandemic. So at a high level, I would say we are in the early part of the third inning of a 9-inning baseball game. If we see the pandemic as lasting about 18 months, and that's an optimistic view, because the hope is that within 18 months we will have a vaccine. We're in the beginning of May and starting month 5, because in many ways this pandemic got going just at the beginning of this year. Certainly that's when the world became aware of it. And the pandemic has already taken an incredible toll across the world. About 3.5 million people confirmed to have the disease and about 250,000 people confirmed to have died from the disease. But all of us believe that the real numbers are somewhere between 10 and 20 times each of those. And so that means that probably 35 to 70 million people across the world have been infected, and somewhere in the order of 3 to 5 million people have already died. And we are still in the early days. We're still in the early days, and that's an important perspective. If you think about the international perspective, the global perspective of how this disease has gone, while it has affected nearly every country in the world, there are sort of 3 or 4 major groups of countries in terms of the strategy they've taken to combat it. And I want to just talk about them kind of in buckets and groups. The first, of course, is China. And the Chinese approach was a combination of ignoring it, and I would argue negligence in the early days, followed by a very, very, very aggressive lockdown. Wuhan was locked down for 76 days. And ultimately, the disease was brought under control through a very aggressive social distancing where people were essentially locked into their homes for over 2 months. The second group of countries that really confronted this disease were East Asian countries, South Korea, Taiwan, Hong Kong, Singapore, and Japan. And while they took slightly different approaches, you could argue that they all kind of bucket into the strategy of jumping out early and really using testing, tracing, and isolation as the main strategy. Certainly South Korea, Singapore, Taiwan reflect this, where they developed tests very, very early. They started testing people quickly, and then built up an entire contact tracing and isolation infrastructure that kept the disease numbers at bay and have allowed those countries, those places, to have relatively low numbers without having to shut down their economies. I want to talk about a couple more models. The third model is what I would say is the Western European and North American model. This model is not all that glorious, and let me kind of lay out what the approach in Italy, Spain, UK, the US has been, which was really to ignore the disease for a while, to fall behind. And once the case numbers got very, very large, in some ways follow the Chinese approach, but not as aggressively, and to do the lockdown while we built up the testing infrastructure. And what we've seen across these Western European countries, and I'm going to give you a couple of exceptions, being Germany and Sweden, and then I'll try to lay out what I think is the big picture point in all of this. But if we look at the US, UK, Italy, Spain response, a lot of people have gotten infected. A lot of people have unfortunately died. Each of these countries was slow to recognize the severity of the disease. And each of them imposed varying degrees of social distancing lockdown to try to curtail and bring the disease under control. The two Western European countries that have been different and have really taken a different approach, one is Germany, which has had an approach that looks a lot like the East Asian approach of much more aggressive testing. They've also had to do lockdowns and social distancing, but not as much, and have had, relatively speaking, fewer cases. And then the most interesting controversial model is the Sweden model, which has had relatively voluntary social distancing, modest amount of testing, and an attempt to see if they can keep their economy going without suffering too many deaths. And the results in Sweden have been that the number of people who've gotten infected and died are much higher than they are in other Scandinavian countries. But at the same time, they're not catastrophically bad as they are in places like Italy. And they have been able to keep their economy reasonably open during all this time. And then finally, I want to talk about India, which is maybe one of the most interesting places of all. Because as opposed to all these other models, the approach that India took was when the case numbers were reasonably small, they went into lockdown and have really stayed in lockdown now for almost 6 weeks. And what India has seen, therefore, is a very low number of cases and very few deaths. And the big question, of course, for India is what will happen when the lockdown ends? How are they going to manage with the disease? So the big picture point is lots of different models, lots of different approaches, sort of the East Asian model, the Western European approach, a few exceptions, and then the Indian approach. And obviously, I didn't cover 90% of the world, but I wanted to give you kind of some of the flavors of what's been happening across the world. Ultimately, every country is using some combination of social distancing and testing, tracing, and isolation. And which approach, what the blend, has really been driven by how much testing capacity there is, how big the outbreak is, and how quickly countries have been able to get going. And so as we look out over the next few months, what I suspect we are going to see is a bit of a reprieve in the Northern Hemisphere. Western European countries, US, Canada, should have a somewhat calmer few months in the upcoming next 3 to 4 months, helped a little bit by seasonality. India, it is hard to tell what is going to happen, but I'm very worried that they're going to see a large number of new cases as lockdown ends. And ultimately, we are all going to go into the fall with what will almost surely be a big second wave. And so when we think about preparing the United States, and now I'm going to talk really about the US, for that, we have to spend the next 4 months really thinking about how to prepare our healthcare system and our public health infrastructure. In my mind, that means focusing on substantially ramping up our testing infrastructure, building up an army of tracers, contact tracers, building up programs for how you're going to isolate people so they can be kept away from others and in a way that allows them to receive some compensation, allows them to get food and housing. So there's a whole set of things that we really need to be spending time on. And then I think you'll hear this much more from Bryony, but we need to do a lot of work on getting our healthcare system through the summer, but really prepared for what is likely to be a difficult fall ahead. And as I think about all of those and realize they are very much global challenges, There are also going to be, I think, opportunities for all of us to learn from other countries and see what the experience of Sweden and Germany really is as the summer months go through. And then this entire idea of a big second wave that I've been talking about that is coming in the fall, we're going to have a better feel for how substantial that is by looking at what happens in the southern hemisphere during our summer. So, of course, when we go into our summer months, Australia, New Zealand, other places are going to be going into their winter months. And so how much seasonality there is to the virus, we're going to be able to understand much, much better by looking at the experience of us and Northern Europe and comparing that to what's happening in the Southern Hemisphere over the summer. And then finally, let me make two more points and then I'll wrap up and happy to take more questions or happy to take questions during the Q&A. One thing I want to talk about is therapy. So last week we got some, I think of as reasonably good news about remdesivir. What's interesting is, there's been a lot of controversy of is it really, is it a home run or not? And if we're going to go back to the baseball analogy where I said we're kind of in the early third inning of a 9-inning baseball game, I think of remdesivir as a solid single and maybe even a double. And let me make the case for why it could be a double. If it turns out that it lowers mortality by 3.5 percentage points, that's the point estimate with a p-value of 0.06. As we follow those patients along, as we get more data, if it turns out that that really is about the size of the effect, that's a pretty big mortality benefit. That's a number needed to treat of about 30, that you save one life for every 30 people who get remdesivir. That would be close to a home run in most other fields. So I see this as a very solid piece of progress, but by no means the only one we're going to have in the upcoming months. There's a whole host of therapies that are being worked on. I think convalescent plasma, getting plasma from people who have recovered, is going to end up being a really important part of what happens in terms of what's going to end up being something that we can use to treat people. People are working on isolating the antibodies that are most effective and building monoclonal antibodies. So there's a ton of work being done. And I suspect that as we go into the fall, we are going to have a whole set of therapies, hopefully, that will have been found to be effective and usable. Let me finish by just talking about vaccines, because vaccines is how this disease comes to an end. Obviously, the disease could mostly come to an end if we just have massive numbers of infections across the whole world and get to what people call herd immunity. That would also lead to tens of millions of people dying around the world. So I think our strategy should be to not do that, but to keep the world as safe as possible, our economies as functional as possible while we work rapidly on a vaccine. So I've been saying 12 to 18 months. Most experts have been saying 12 to 18 months. There are, as of right now, at least 7 vaccines that are in clinical trial. Most of them are in phase 1. A couple of them are entering phase 2. No guarantees that any of these 7 will end up working out. And there are probably another dozen that are going to go into phase 1 clinical trials in the next month. So, the idea of building a vaccine for the first time in human history, building a vaccine against a coronavirus all the way to completion, gives a lot of people pause that maybe we won't be successful. Maybe we will not be able to get a vaccine ever or not for years. But what gives me optimism is the bottom line that we are taking so many shots on goal, as it were. We are trying so many different ways, so many different efforts, that one of them is likely to work. Are we guaranteed success? We are not. But I would be very, very surprised if we do not have a vaccine that is effective and safe and available to a large chunk of the world's population sometime in 2021. Obviously, we'd love to all see it early in 2021. It may not come till later of 2021. But there is a vaccine at the end of all of this that I'm very optimistic we're going to get. And that's how this finally comes to an end. Last point, and then I'll stop. So the final point is this is really a transformational event. This is not some inconvenience, something, it's obviously incredibly inconvenient, but the pandemic is a once-in-a-century event, and it is going to change everything. It is going to change societal priorities. It is going to change social structures, and it is certainly going to have a very profound effect on the healthcare system. And that it is really critical for us to think about, because one of the things that we will want as we emerge from this pandemic and as we go through the pandemic is we will get to ask the question, what kind of health system do we want? What do we want to rebuild once we get through this? And I think there are important opportunities for doing things differently. And let me not say too much more right now, because I want my co-speaker to have a chance to delve more into some of these details. But I will just finish by saying I think the opportunities are substantial, even though obviously we are going to be going through a difficult time over the next 12 to 18 months. All right, so let me stop there and Sachin, turn it over to you.
Ashish, that was a terrific overview and exactly what we were hoping for. So thank you very much on behalf of the journal and the listening audience. I thought that was a terrific overview of where we are in a global and comparative perspective. And I think you ended it on just the right note as we transition to Bryony, who is Chief Strategy Officer at Blue Cross Blue Shield of North Carolina, who's thought a lot about what U.S. healthcare may look like in the post-COVID world. And I will now turn it over to you, Bryony.
Thank you so much, Sachin, and thank you, Ashish. As Sachin said, my name is Bryony Winn, and I am the Chief Strategy Officer of Blue Cross North Carolina. I do not hail from North Carolina, as you can probably hear. I am Zimbabwean and have lived around the world, and so while my comments will be focused mainly on the U.S., my sports analogies will not be baseball, they'll be cricket, Ashish. I think Ashish ended his remarks perfectly. This is a truly transformational event for our society and for our healthcare systems. And there are three things I'd like you to take away today. The first one is that COVID exacerbates existing fractures in our system. And all the concerns that we have in business as usual times are under an even greater spotlight now. But the transformational nature of this event also offers a spectacular opportunity for positive change. The second thing I'd like you to take away is that this change requires action. It won't just happen. There are thoughtful strategic choices that need to be made by healthcare and other leaders across the globe. And you can't take advantage of this without a deep understanding of the dynamics of this industry today. And that includes the economics of the industry globally. And the third thing to really get across is, however you define positive change, getting value out of healthcare, making progress, it's essential to realize that this is not a business. Healthcare is a deeply human part of our global fabric. And so we have to be very precise that making progress means being deeply in tune with the people we serve as an industry, and frankly, with the people who do that work. Unlike other industries, the supply chain, is not largely a bunch of widgets. These are human beings. The doctors and nurses and work carers on the front line are who we're talking about today. And so those are the three things I'd like you to take away. Let's start with the macro picture here. This is a U.S. view, but we spend $3.6 trillion on healthcare in the U.S. every year. This is about 18% of GDP. And to put that into perspective, it means you could buy these three companies, Amazon, Apple, and Microsoft, in cash. This is an incredible amount of money. And just a single country view. Obviously, we spend much more globally. And what that means is the sheer enormity of the healthcare system and the way it is entangled with lives and livelihoods and the economy across the globe means that any massive transformational change here is going to have a profound impact pretty much in any sector of the economy that you look at. The second thing to look at from an overarching economic perspective is who pays for this care. And this varies widely across the world, but essentially there are three groups. Consumers, and in the US they pay for just under a third, so $1 trillion a year. Employers, through employer-sponsored insurance, and the government, who pays less as a percentage in the US than in many parts of the world, but still a significant amount, over 40% of all care. And for me, as we think about the world going forward, the importance of this fact is that this is going to be a truly integrated effort and solution, with governments, individuals, businesses, all working together to drive the positive change that I believe is possible and that Ashish mentioned earlier. The complexity of this becomes even more acute when you look at the profit distribution of the industry. And again, this is just a US view, and this was in a 2016 article published by McKinsey & Company. But the way to read this chart, and it's a bit of an eye chart, is that the size of the box is the relative amount of margin made by each of the players. So, for example, you'll see right on the right, pharma and biotech make the most margin in our industry as a single group. Providers, unsurprisingly, as a collective, make 54%, being the folks that deliver the care. Understanding the web of interconnected businesses, financial and economic opportunities, and who really is responsible for the flow of funds from an economic perspective is going to be incredibly important as we look at what incentives are at play to be able to take advantage of in the new world. Another point you just get from the chart is look at what an incredibly complex system when we have all of these groups of people working together that we have created, at least in the US. And we have seen unprecedented levels of cooperation, I think, across many of these sectors today. But it has taken a truly global crisis to get there. And this is something that as we thoughtfully construct and rebuild what is the new world of healthcare that we're going to need to look at. I'd like to turn now to a much more human view. From a macro perspective, there is a lot of money in healthcare. There is a lot of money currently being made. There is a significant amount of resource at our disposal to be able to create the right incentives to change the system. At a micro perspective, it's a very different picture. And that is, at least in the US, affordability is one of the greatest crises of our time. Look at the family here. These are a real North Carolina family. Their names are the Overmans. They have 2 children. They are middle class by any standards, making just less than $120,000 a year in salary, which is, a decent salary in the US. And yet they spend, on average, over 21% of their income on healthcare. The Overmans are not alone. Even pre-COVID, 29% of Americans reported problems paying their medical bills. This is a staggering number. 14% of Americans post-COVID have said that they will actually avoid care due to the cost. And this is despite the fact that much of this care is being made free by different payers across the country. That is more, those 14% of people who are understandably afraid for their own financial futures are also putting, an entirely public health at risk. And finally, and this is where we get a little bit to the opportunity, there have been 900 million is the estimated number of COVID-related virtual visits for 2020. So if we look here at the opportunity for a new system and what I think is going to be at play and what I hope will be at play post-COVID, is that innovation at really low cost will accelerate. Low telehealth is one example of that. The world of healthcare typically has been innovation happened for the people who could pay for it. So that was essentially the employer-sponsored insurance, and trickled down to government-sponsored healthcare and Medicaid in the U.S., which is the program with the tightest economics. What I see going forward is innovation will happen for Medicaid. It'll happen at low cost and then percolate up. And I think that will be a game changer and a forced game changer for the world. A second place I'd look, and going back to the human part of what this transformation must mean, meet Penny. Penny is another member of ours, and we met Penny at 26 after her second stint in rehab for opioid addiction. Penny describes her life as being something between a pincushion and a ping pong ball, where from the age of 8, she was bounced across the healthcare system, being tested first for ADHD and then for a plethora of other mental illness and conditions. She said at about age 17, where she had never found anybody who truly got her in the healthcare system, she started self-medicating, firstly with alcohol and then with drugs. And as I said, we met her after her second stint at rehab. Penny, too, is not alone. 45% of U.S. adults are reporting negative impacts of COVID on their mental health. This is a staggering number, and especially one that is reported, because mental health concerns are still something that are not talked about as much in our society. Substance use ranks number 1 in terms of cost drivers at the emergency room in North Carolina. More than anything else, more than car accidents, more than heart attacks, it's substance use. And, a number of recent articles, and this is stats that is incredibly interesting for me, is that 29% is the increase of coronary heart disease associated with poor social relationships. And so the impact of society and loneliness and mental health on health is incredibly well studied and incredibly profound. The opportunity here for me is trifold. Firstly, I think as an entire society, we're going to integrate physical and behavioral health much more closely. We can all talk about, secondly, is the impact of loneliness and societal health on physical health will become much more clear. COVID and physical distancing has really shown the world how reliant we are on each other in a very human, social way. And thirdly, I think we're about to see a bunch more crises once this physical one is over, of how we deal with the remaining social crises related to COVID, food insecurity spiraling across the U.S. and globally, mental health conditions. How are we going to deal with children who have not been able to have the schooling that they typically would? And I think there is an immense opportunity for positive change to integrate all of these public health criteria into the more formal healthcare system. Leading on from that, and looking at the children and how different socioeconomic and geographic considerations play into health, I think will be another important opportunity for our system. 26.5 million is the number of unemployment benefit applicants in the U.S. since mid-March. There is a staggering crisis of unemployment in this country and globally, and only set to increase. 25%, that is a quarter of all American children, are at risk for food insecurity. And This is at the same time as 3.7 million gallons of milk are being dumped on a daily basis in the US because they can't be transported to the places that need them, and demand, at least in a formal basis, has gone down. And here is another opportunity that I think we need to challenge our healthcare system to look at, and that is the interconnectedness of the supply chains that relate to health. And this is both healthcare as formally defined, access to primary care doctors in rural areas, and mental health practitioners across the board, but also supply chain defined more broadly. What does the food supply chain look like in the US? There is currently more than enough food in the country, and yet we have not integrated the way we work enough to get it to the people who need it. And frankly, for a country as wealthy as the US, a quarter of all children at risk for food insecurity is, an absolutely moral catastrophe. And finally, and I'll end here before we go back to a group discussion, is given the affordability crisis, given the real need for a strengthened public health system and the resources it takes to create that, I think we need to think about the different areas of the healthcare system who are currently making money and what value looks like. And this is one that is, a truly global challenge, and that's of pharma. Ashish talked at the end about the at least 7 vaccines in trial at the moment. There are well over 500 clinical trials happening today across the pharma industry for treatments to COVID-19. And I think what this has brought into stark contrast from previous discussions is the entire pharmaceutical industry plays a critical role in keeping us all safe and healthy. And after years of being sort of battered around in the media and the industry for some, fairly terrible behavior, I think the public awareness of the real need for a strong research development pharmaceutical industry is coming to the forefront. However, there are still challenges here that remain, and I think this is something we have to think about. For example, 30% of a payer's medical cost base in the US is attributable to pharma. A third of all costs in healthcare go to drugs, for us at least. And this is growing at a much greater rate than any of the other parts of the system that we pay for. And this is at the same time as the average operating margins for the top 25 pharma companies globally is 22%. This is really high. So the complexity of we need pharma, we certainly need them at this time, and R&D is expensive, but coupled with the fact that public health is in a resource crisis, and even for individuals, affordability remains a very pressing issue across the US and globally. How do we redefine with the pharma industry across the entire healthcare industry what value means? And so I will leave it at that. I mean, I'll repeat what I said at the beginning, is that COVID really gives us an amazing opportunity to change things, but you have to do this by being practical and strategic around the resources in the industry and really putting humans at the center of what we do, and making this more a human challenge than anything else. I will turn it back to you, Sachin.
That was terrific, Bryony. Thank you so much. Really appreciate the thoughtful perspective on the macroeconomics of U.S. healthcare and your perspective on how it'll evolve in the midst of COVID. I wanted to ask you both a question to start out with. If we had a do-over here, if we could have redone our national response to COVID in the United States, or even our global response, Ashish, if you want to take on a broader scope, what would we have done differently? What does that look like? And could we have been in a different place had we started a little bit differently. Ashish, maybe do you want to start, and then we can,
Sure.
and then Bryony, take it from there.
Yeah, I'm happy to, because the short answer is things could have looked very, very different. So let's think about what that, and let's stay realistic of what's possible. Imagine that by mid-January, when it was clear that the disease was spreading beyond just China and there was a test developed by WHO, imagine if we took on that test and ramped up using that test so we had a functional test by let's say mid to late January, kind of along the lines of what South Korea had. And that as people started arriving, as we started seeing cases in places like Seattle or in New York, that we started doing extensive testing across the country and found the early cases and found the early outbreaks that were starting to happen in the U.S. Imagine that at that point we had federal leadership that talked about what was likely coming down the pike and started implementing very mild social distancing stuff so that we started canceling big gatherings in February. Where do I think we would have been now, or by late March, early April? I think we could have kept our economy reasonably open, or maybe not. Maybe we would have had to shut things down for short periods of time. We certainly would not have the 69,000 deaths that we have in the country. And I think we easily could have ramped up our testing and isolation strategies so that we would be in much, much better shape as we were coming through April into May. Why do I think this is all possible? Because literally about a half a dozen countries did this. And even countries that had some missteps initially, like Japan and Germany, I wouldn't say Germany had missteps, but Germany wasn't quite as aggressive as they could have, quickly were able to pivot and get there. And Germany on a per capita basis has had far fewer deaths, far fewer cases, and their economy is more open now than the U.S. is because of those changes. So that's certainly for the high-income countries. For low and middle-income countries, and by the way, other success stories are like New Zealand, which has done a terrific job. Low and middle-income countries, it's a much harder set of challenges because social distancing and lockdown extract an enormous cost on the world's poor. And I know that's what India has done, but I think there, again, more aggressive ramping up of testing early could have maybe helped prevent some of that. But it's just a different set of challenges that I don't have as clear a set of answers to what should have been done differently.
Thank you, Ashish. Bryony, do you want to offer your perspective?
Yeah, I definitely can add some on that. And Sachin, I'll take it a slightly different direction. I think, Ashish is clearly the expert on the overarching view. One of the things that I can say is I think the health industry actually acted really quickly. Taking out any political pieces, things like payers were very quick to pivot to paying for telehealth in an unprecedented way, not only for COVID-related sort of conditions, but across the board, including paying full rates for things like telepsychiatry. Another big change were reducing the administrative complexities very quickly that are often asked of providers and dropping them in areas where there was going to be a surge. A third area were, how we license physicians across states and making those boundaries disappear over this time. And so I think from the folks deep in the health system, I think there's actually been an incredible and almost unprecedented speed here. And for me, that's really exciting because I think it's less it's less about we acted too slowly. I think here it's we acted really quickly, and can we continue it? And how do we continue it going forward?
Can I throw in one quick thing, Sachin? I completely agree with what Bryony said. But there's one way in which the healthcare system response wasn't optimal. And I'm trying to pick my words carefully because I don't actually think it's the fault of the people within the healthcare system. I think it's a consequence of the blindness we had about the disease as it was spreading across the U.S. all through February into mid-March, is when it became clear that we would have to shut down, that we would really have to go into lockdown mode. You did a lot of very aggressive things, and a lot of it very good, as Bryony has said, but some of it like canceling all elective procedures. I not only get why we did that, I advocated for that. So I think that was terrific. But I had a sense then, and I'm increasingly getting a sense now, that those decisions were incredibly expensive. I still think they were the right thing to do when we were confronted with the disease as it was. But if we knew in early February that we were going to end up in a position like this, we could have handled all of this very, very differently. And I'm worried that a lot of people were hurt and some number of people died during this time period, not from COVID, but from the spillover effect of the response to COVID. And again, I don't have any criticism of either the doctors or the hospitals or the payers, but I do think that when we go into the fall and have to think about shutting down again, we're going to want to do this very differently.
Yeah, I mean, on a personal, my personal perspective is that some of what this crisis has underscored is the fact that we don't really have a healthcare system per se. We have a lot of different actors kind of operating independently through loosely coordinated activity. As somebody who's worked in the business of trying to change healthcare over the last number of decades, my belief is I think shared by both of you that this is potentially the disruption we needed to start moving away from the high degree of fragmentation that we have towards a more systematized, organized view of healthcare. What does the U.S. healthcare system look like in 5 years coming out of this? We're in the middle of an election year. Use your crystal ball and maybe predict the 1, 3, 5 year view of where this goes. Maybe Bryony, we'll start with you this time, and then pivot to Ashish.
Yeah. No, Sachin, it's a great question, and I struggle with crystal balls. I think we could be in two very different places. And I think it depends very much on actions we take now, for the short term, for the fall, for the medium term, next year, and then for the 5-year view. On the most positive note, I think we could see a much more integrated system with the financial challenges experienced by the whole system, really making us focus on what real value in care looks like. And I mean things like truly integrated behavioral and physical health, understanding what drivers of health or social determinants of health impact real human beings, and how to put that together, and a much strengthened public health system, as the U.S. especially has realized that you are only as safe as a human being as the least healthy or least safe person next to you as part of this crisis. So health becomes much more a right across the whole country. I won't opine on politically how we get there. I think there are many ways that could happen productively. There are many policy and political solutions. There are also private sector solutions. But I think there is a real opportunity to get there now. And I think a 5-year view is a realistic time frame. What really concerns me is there is an equally, in my view, equally likely view that we go back to even worse business as usual, with now everybody in a resource-constrained environment looking out for just their little piece of the healthcare pie, and creating a highly fragmented and then highly disparate system between the wealthy who can afford to pay for not only all of these little pieces, but also for the Sherpas to guide them through this complex, ridiculous system, and those in the U.S. who don't have resources, who are at the mercy of a very weakened public health infrastructure.
So let me add a couple of things. Let me just add a couple of quick things. First is I see a health system that is far, far more flexible than where we are today, or I should say where we were 3 months ago. I don't know where we are right now, but in the middle of this, but where we were 3 months ago. So many of the policy changes that we put in, CMS and others, meant to be short-term, temporizing to get us through the pandemic. We're not going back on them. We're not going to be like, okay, now everybody's back to MIPS and all these quality measures. There's a sense that like this is not going to work. I think no one's going to be interested in going back. The idea that, we won't pay for telemedicine in the future, I think we're not going back. We will pay for telemedicine. Will it pay the same amount? I don't know. There may be some changes. But you can just see all the changes that have happened. Most of them are going to stick for the long run. So I think most of them are good, by the way. So I see that as a silver lining. I think there is going to be one of the ironic parts of the healthcare system is that as spending in healthcare has gone up, spending in public health has gone down, and they're related. That we've actually been taking money out of the public health system to pay for a lot of healthcare services, and I think there's going to have to be a massive reinvestment in the public health infrastructure. And that money's going to have to come from somewhere. And it may come out of the healthcare system. It may not. I don't know. But the point is that balance, which has been heading in one direction, I think is going to start getting rebalanced a little bit with more focus on public health. Because if there was ever a thing that made the case for public health, it is this pandemic. And third is, I think there is a chance to integrate care in a much more profound way. And that doesn't necessarily mean Medicare for all. Medicare for all doesn't get you to automatic integration. I mean, it's not like people over 65 all have perfectly integrated care and they have Medicare. So I don't mean sort of simple sloganeering like that. I think there is an opportunity to re-envision what care looks like for people in a much more integrated way. So in that way, in all of those ways, I agree with Bryony and think the opportunities here are more positive.
Ashish, I really like what you've just said about health as well as public health care. And for me, that probably is the most exciting opportunity here, is how do we re-envision health? And this is why the pieces of food insecurity, the mental health, effects post-COVID that will affect a much broader swathe of the population all come together. In a way that I think at least the discourse has been opened in a much bigger way because of this crisis than we had before.
Yeah. Both of you use the word integrated, and I'm not sure what you both mean when you use the term. I think it's one of these terms of art when we talk about healthcare that I think means different things to different people. Would each of you mind, maybe double clicking on your vision of what integrated care really looks like? Maybe Ashish, since you most recently said it, you could dig in a little bit deeper, and then Bryony, maybe your perspective as well.
So there are facets of care that is about integration. So integration to me is not a organizational or a structural feature, like you're part of an integrated delivery system. What I mean is that your care is integrated, and that begins with your information is integrated. And also, it does not mean it has to sit all within one electronic health record. It could sit in multiple places, but there has to be some way in which all that information comes together and is integrated. So that's one really important feature of integrated care. To me, another feature is that wherever you're getting care, even if it is from 6 different institutions and 6 different things, that the priorities you set up for yourself, the things that you value most, are all reflected in the way that set of care delivery is, or the set of care is delivered. Right now, what fragmentation means often is that providers are working at odds with each other because they don't know what the other person is doing. There's a ton of duplication, there are a ton of errors. And I can imagine both through information integration, but also really through other mechanisms, so we could get care that is much more aligned with what people actually want out of the healthcare system. So those are a couple of the ideas that I've been thinking about with integration.
Yeah, Ashish, I would agree. I mean, Sachin, I'll take an example. Penny, who I talked about, who we met after her stints in rehab, had an appendectomy at 17 and was prescribed opiates after that, with no recognition of her previous substance use, because her surgeon just didn't know. Her doctor just didn't know. And really treating, a person as, the what is, treating a person as a single human being rather than a collection of diagnoses is what I'm looking for. And Ashish is right. It's not about a single system or a single app or tool or infrastructure. But, in the world of opportunity, redesigning this entire system around how do we understand that there are so many facets of a human being's existence that impact their health. That's what I'm talking about.
Got it. No, that's really helpful, and I think paints a vision of optimism for where we might land coming out of this, really unprecedented time. I wanted to spend a little bit of time thinking about, things that people can do in their individual organizations tactically to really either mitigate COVID itself or, something you said, Ashish, actually caught me, which was this question of, the untold cost of people who are not affected by COVID, the untold healthcare costs of people who are not affected by COVID, who still have healthcare needs. People are still having heart attacks. They're still having strokes. They're not necessarily coming into the emergency room in the way that they could. And there's a lot of potentially avoidable morbidity and mortality. Both of you, occupy leadership positions in your respective organizations. What are some tactical things that organizations should be thinking about as we kind of enter, innings 4 through 6? Pardon me, Bryony, for sticking with baseball instead of cricket. As we get to the middle of the game, what should we be doing? What are the things we should be focusing on? What are the things we should be thinking about? PPE is obviously, kind of on the, was kind of a phase 1 need. What's next?
Yeah. So let me start with just a couple of, we'll keep it pretty tactical here. The healthcare system, and if you broaden it to go beyond doctors' offices and hospitals, so also think about long-term care places, post-acute care places, nursing homes, skilled nursing facilities, et cetera. They were really, in different ways, really pretty central to how things went wrong the first time around. And so we have to put a lot of, I think, energy and focus on, quote unquote, strengthening them for the next phase. So what does that mean? We have to come up with a really aggressive testing strategy for healthcare workers, for nursing home residents, for workers who work in those places, for visitors. Many, many times we saw people, one of the biggest tragedies of this was the number of people who died alone because they couldn't have family there. And we have to find ways to think about how to be able to have families come in and visit patients. And that means being able to test people more readily, being able to protect people more aggressively. So there has to be an entire strategy around protecting the healthcare system and its workers and its patients that I think is going to be really critical. And then the other part is I want to make sure we spend the summer months not just catching up on all the deferred care, which may be deferred, but it was not, it was not discretionary. It was necessary. But also really coming up with a plan for if we get with a big wave in the fall, and if things go badly, how do we make sure that all those people who are dependent on the healthcare system for their lives and for their well-being, that we can take care of them? And you can imagine things like setting up very separate non-COVID facilities versus COVID facilities. You can imagine there's a lot of things we can do tactically, but we've got to start planning for that now because the fall will come. And when it does, probably another big wave will come. And we're going to have to come up with very specific strategies for how to care for people and get them through this difficult time.
Sachin, I would 100% agree with Ashish. And I think we need to be thinking tactics now for the fall, and we need to be thinking with the same granularity and precision about tactics for the 1, 3, 5-year plan that we talked about. This is not the moment to be reactive. And I said before, I see two very different roads that we could go down here. And what defines the road of real opportunity is proactive behavior and real choice. And I think leadership needs to come, collectively from all of us, from the group of folks on the phones listening to this. You can definitely, some of this may come from governments across the world. Some of this may come from the federal and state government here, but I don't think that anybody looking at health should rely on that. What are the proactive tactical things that we can do now, working as a system, working in unity, in consortia, that will make a difference in 3, 6, 9 months and 5 years?
Great. We're reaching the almost the top of the hour, so I wanted to maybe offer both of the speakers, Ashish, Bryony, an opportunity to just say some closing remarks. Hopefully we can leave the audience with a note of optimism. That would, I think, be preferred, but obviously realism is important too. So I'll ask you to end with some closing remarks. And I want to just thank the listening audience for tuning into this webcast. I think it's been a terrific discussion. I want to thank both the speakers, and I'll ask Ashish to say his closing remarks, and then Bryony, and then we will bring it to a close.
Great. So Sachin, thank you for moderating. This was it was an excellent discussion, and I want to maybe just make one point. So if you listen to my talk, you can feel, I think we all feel, the sense of gravity, the sense of weightiness of where we are at this moment, and how hard the next 9, 12, 18 months are going to be. And I don't think we do ourselves any favors by acting like that is not correct. But I also think that how it goes and how we do is almost completely within our own control. Some things are not. We can't completely control whether a vaccine will come in 9 months or 18, or whether some therapies will work or won't. But we can control almost everything else in this disease. This disease may be deadly and may be complicated, but we understand the basic rules. And if we can implement some basic public health things, modest social distancing, testing, isolation, we do a bunch of smart stuff, we can get most of our lives, not 100%, but most of it. And we can get through the next 12, 18 months unscathed without destroying our economy. It's completely within our capacity to do so. And it's going to take all of us acting individually and then pushing our political leaders to get us there.
Ashish, thank you. And I will pick up on the individual action point and return to, one of my 3 points earlier, which is making progress here and real change is understanding that healthcare is deeply human. And part of that is thinking about your role as an individual human and what you can do to make things better. And that spans from individual choices to stay at home when you need to, right through to ideas of systems and organizations that can shape what roles are you taking to help leaders politically understand what the right thing is to do and to cooperate with the different players in your own ecosystem to do the right things where you can. I would not underestimate the impact you can have by making individual decisions well in times like this. I think when things appear so brave, one of the risks is that, you say somebody else is going to do it. And I don't think that's that time here. All of us are the ones to do it.
Great. Well, thank you both for a really enlightening discussion, engaged discussion. Thank you all to the listening audience. I know we had a terrific, pre-registration of over 1,000 registrants, so appreciate all of those of you who took time from your busy schedules to join us. I hope you'll follow Healthcare the Journal, both on LinkedIn as well as Twitter, and that we can continue to count on you as part of our broader community of readers, and we'll look forward to engaging with you all soon. Thank you very much.